welcome to our HRT webinar. We're so grateful to you all for coming tonight, and it's really nice to see so many people on the call. I understand we've got representation from across the UK and even internationally from Malta, so that's really lovely. Thanks so much. My name is Katie Cathro, and I'm the Education Lead for Scotland's South East faculty. I'm also a GP in the Scottish Borders in South Scotland. Before we start, just a little bit of housekeeping. We are recording this tonight, so I hope everyone's happy with that. But please do not feel that you need to put your cameras on. We can keep everybody nice and anonymous. Dr. Rodger will be presenting to us shortly, but please use the chat function on Zoom for any questions that you may have, and we'll address these at the end. So I'm delighted to introduce my esteemed colleague, Dr. Faye Rodger, who is a consultant gynaecologist based at the Borders General Hospital in the Scottish Borders. Dr. Rodger qualified from Edinburgh University Medical School in 1992 and pursued a career in obstetrics and gynaecology. She was awarded a prestigious MRC clinical fellowship and went on to complete her MD. Hope I'm getting this right, Faye. She went on to complete her specialist training in South East Scotland and qualified with a subspecialisation in reproductive medicine in 2007. She has been a consultant and British Menopause Society recognised menopause specialist for over a decade. So in the Scottish Borders, we're very lucky to have a specialist to turn to for all things menopause. Dr. Rodger takes a holistic approach to her patients, offering both conventional and non-hormonal approaches. So this evening, Dr. Rodger will discuss new HRT developments, the role of hormonal testing, the new postmenopausal bleeding guidelines, and tips on how to adjust HRT for women who are bleeding. And she will also give us an insight into Veoza, a new non-hormonal medication for vasomotor symptoms. So on behalf of RCGP South East Scotland, I would like to thank you all for coming and to hand over to Dr. Rodger for tonight's webinar.
Okay, so thanks very much, Katie. That made me sound much scarier than I actually am. So as Katie says, I am a menopause specialist who works in the Scottish Borders with Katie, and I'm going to talk a little bit about menopause and HRT tonight. I'm a menopause specialist, I'm a menopause trainer. I am 56 and I'm married to a GP, so I have some insight into what you guys have to do day in, day out, and I hope this is going to be pitched at the right level. Any questions, please feel free to put them in the chat. So I'm just going to start sharing my screen. Is that sharing successfully, Katie?
Not yet.
Okay, let's just wait a little minute.
Nothing coming through just yet, Faye.
We are getting there.
There we go.
Are we there?
Yeah, we can see it. And then if you just make it full screen, fantastic.
Excellent, perfect. So I'm going to just go through a little bit about what we're going to talk about. So we're going to talk a bit about HRT prescribing. I'm then going to go on and talk a little bit about the role of testosterone, because I think I get asked about this quite a lot, and I've tried to keep this talk to addressing the things I get asked about a lot by both patients and by GPs. We'll mention a little bit of stuff about non-hormonal alternatives and fezolinetant, which is the new non-hormonal alternative that might be quite useful for some women. I'm going to talk a little bit about the new British Menopause Society guidance on women who have abnormal bleeding on HRT. And we'll talk a little bit about HRT prescribing for women who have other health problems. And then, so the last third of the talk, I've done some clinical cases. There's probably too many of us here to discuss them as a group, but I'll go through them one by one and kind of explain the rationale for how we treat these in my menopause clinic. And again, happy to answer any questions on these at all. Okay, so let's get started. So this is really starting very basically, hormones and HRT. So HRT contains estrogen, which is the hormone that makes everybody feel better and gets rid of the majority of menopause symptoms. And the main things that we can change about the HRT dose is either the change about estrogen is the dose or the mode of administration. So we can give the estrogen either orally, transdermally as patches or as gels, and very occasionally we give it as implants as well. And if patients aren't feeling great on it, we can alter the dose or we can alter the mode of administration. The progesterone or progestogens are only there in order to protect the uterus from the effects of the estrogen. So no uterus, you don't need to have the progesterone. We have some new guidance over the last sort of 18 months from the British Menopause Society that the strength of the progesterone needs to reflect the estrogen dose. So if women are on high dose estrogen, what do I mean by that? I mean 100 microgram patch, 3 or 4 milligrams of oral HRT, 2 sachets or more of Sandrina, or 4 pumps or more of estrogel, you might need to give them more progesterone, particularly if they're on Utrogestan. And there's really good advice on the British Menopause Society about practical prescribing. And that applies to both women who are on continuous and sequential HRT. And the thought is you just need a bit more progesterone there to protect the endometrium from the effects of the estrogen. Different progesterones have different side effect profiles. So some progesterones might be less side effecty than others. Most women will suit standard progesterones, which tend to be norethindrone, medroxyprogesterone acetate, dydrogesterone that are standard HRTs like Everel or Alest or Femiston. If women have side effects, then they can be given Utrogestan, which is oral micronized progesterone, and it tends to have a better side effect profile. But I sometimes think progesterone is quite an idiosyncratic drug, and sometimes you find one that really suits somebody, and sometimes you get somebody who's got side effects on Utrogestan, and they don't have side effects on other progesterones. Okay, so we talked a little bit about estrogen. So the standard oral doses are 1 milligram or 2 milligrams, and they come as estrogen by themselves or estrogen with combined progesterone in most cases. Transdermal patches, 25, 50, there's also 37.5 in there, a 75 and 100 microgram patch. I'm sure that you all prescribe these. And the equivalent doses of estrogel are 1, 2, 3, or 4 pumps, with 1 pump being equivalent to 25 micrograms of transdermal estradiol. In general, start with a low dose, 25 or a 50, and titrate upwards within the licensed dosing until their symptoms are settled. And as the British Menopause Society annual conference this summer, and there was a whole session on why we don't think that serum estradiol levels are particularly helpful in deciding which dose for somebody to be on. We'll see a bit more about when they might be useful later, but we're really moving away from testing these. We think they're unreliable. They don't actually give good data about absorption. And we should really just go on how women are feeling. And if they still have symptoms, think about increasing the dose within that licensed dosing regime. Side effects from progesterones, as I've said, can be really unpredictable. Bloating, anxiety, and headaches are some of the commonest side effects we see, but women can get constipation. They can sometimes find that they have really severe mood disturbance on it. And again, some women just find a progesterone that suits them better. If they have got side effects on one progesterone, it's worthwhile trying a different progesterone. And in particular, Utrogestan tends to be a little bit less side effective than some of the other women who have problems. Mirena's a really good choice for women who have side effects on progestogens, and often women are a little bit resistant to this. And sometimes I think that resistance comes from having horrible side effects on progesterone and then thinking they're going to be stuck with something that they can't stop or take themselves. And I think that the trick with Mirena is if somebody's having horrible side effects on progesterone, to reassure them if they come back on the Mirena that we will take the Mirena out. And women really worry about this, but with reassurance, you'll find that it will suit a lot of women because so little of the progesterone gets into their circulation. Your other option is Utrogestan. We usually give this orally at night time because as a sedative effect, and you might as well use that to make people sleepy. In the morning, they're just going to feel sedated all day. You can give it vaginally, that's unlicensed, but there are some studies that show it actually does work to protect the endometrium. And the dose is usually 200 milligrams vaginally every day on a continuous regime. It's unlicensed vaginally, and I do tend to scan my patients on vaginal utrogestan on a yearly basis to make sure their endometrium isn't thickened. And I have a very low threshold for investigating them before then, just because we don't have good license data that it is effective at protecting the endometrium. So should we start a tablet or should we start a patch? And I think it really comes down to patient choice. The main advantage of transdermal estrogen is it doesn't carry a risk of venous thromboembolism. And for women who have never had a clot, then we should probably be using transdermal estrogen if they have risk factors for venous thromboembolism. So if they're immobile, and risk factors also include a BMI over 30, and that's probably about 75% of the population I see who are thinking about starting HRT. So it's a very safe way of starting HRT. And I think the other good thing about transdermal estrogen is it has quite a big dosing regime. So you've got a lot of choice about where you start and where you can go with it. For women who have had previous clots, we don't actually have good data to say that transdermal estrogen doesn't increase the risk of a recurrent clot. And that probably requires a bit of careful discussion. And we'll say a little bit more about that later. But you can't just assume it's free of clot risk for that population. A lot of women find a tablet's much more convenient. They can just take it once a day, don't have to faff about changing patches or waiting for gel to soak in. And in general, oral HRT does have a better bleed profile. It does carry a small risk of venous thromboembolism though, and it's just important that women are aware of that if they choose oral. And I want to say a bit about Tibolone, which I actually think is a really good drug. It's a synthetic molecule, and it's just one molecule. It's got a bit of estrogen effect, a bit of progesterone effect, and it's also got a bit of androgen effect. So it might be quite good for libido if somebody has libido problems. And it also has a lower breast risk than some of the other conventional HRTs. But there is a trade-off. It has a higher clot risk than other oral HRTs. So it's about finding out what's important to your patient and what their priorities are. So what benefits does HRT have? And when I see a new patient who's thinking about starting HRT, and often I see women who are quite medically complicated, we tend to talk about the balance between benefits and risks. So the first big benefit is it works really well for most women. So it's really good at controlling most menopause symptoms. I do think that the landscape of menopause has changed quite a lot over the last 10 years that I've been a menopause specialist, principally because of all the social media and publicity it's been on the TV and a lot of the Davina McCall stuff. And I'm increasingly seeing women who have symptoms that I'm not necessarily sure are due to menopause, and I'm not necessarily sure are going to respond to HRT. If you are not sure, it's okay to start a trial of HRT and see if things resolve. There will be a bit of a placebo, perhaps. HRT does reduce coronary heart disease if you start before you're 60 or within 10 years in menopause. And we're not at the stage where we would want to do that for primary prevention of coronary heart disease, but it's important to put into that mix of benefit versus risk. It certainly reduces the chance of getting osteoporosis. And the thing that you never really see is that it reduces the risk of bowel cancer as well. And we've got fairly good data that it reduces bowel cancer. Risk, everything in life is a balance. So there is a small risk in breast cancer diagnosis, and there are lots of different figures out there. I tend to use the MHRA website figures for women, which are up to date. They probably are the scariest of all the figures that are out there, but I think that they are the figures the government publishes, and they deal with conventional HRT, not with natural progestogens. But I think it is important to know about them. The risks of breast cancer are slightly higher for continuous combined than for sequential HRT, but long-term use of sequential HRT carries a higher risk of endometrial cancer. So it's again about that balance. And the risk of a breast cancer diagnosis, according to the MHRA data, is for a woman in her 50s who uses HRT for 5 years and then is followed for 20 years. One extra woman will develop breast cancer in 50 for continuous combined HRT, and one extra woman will develop breast cancer in 70. You'll see that I've said breast cancer diagnosis. It doesn't seem to increase breast cancer death, which is interesting. And there's a theory that perhaps it makes breast cancers that were there anyway easier to detect. We don't quite know why that is. It's quite controversial that estrogen-only HRT increases or decreases the risk of breast cancer, and there is controversial evidence each way for this. We just don't know it. I think at worst the effect is small, and the MHRA data quotes the risk of 1 in 200 for estrogen only. So there's something about the combination of estrogen and progesterone. And the type of progesterone might have an effect. So there's quite a lot of stuff on social media about eutregestan being breast cancer risk-free. There's one big retrospective study done in France called the EN3 study, and it looked at many thousands of women who had developed breast cancer on HRT. And what they found is that women who'd used eutregestan for 5 years or under as the progesterone part of their HRT, along with estrogen, did not have an increase in their breast cancer risk. However, this is only one study and hasn't been replicated, and it's a retrospective study. We don't have a lot of data on Mirena. The scanty data we do have suggests the risks of Mirena, which you might think would be less, are actually similar to conventional HRT. There's a slight increase in risk of being diagnosed with ovarian cancer with HRT. It's about 1 in 1,000. And I've already mentioned there's a small risk of venous thromboembolism with oral HRT. So it's about that risk and benefit. And I think sometimes it's very difficult for women to know what their balance of these risks is going to be until they've actually tried HRT, so that they can find out how much benefit they actually get from it. So difficult things. So women with Mirena or Levocert. So Mirena and Levocert are both able to be used for 5 years for HRT opposition. Just recently, we've had a few women pop into our referral inbox who have had Mirenas for much longer than 5 years and have been used for longer than they should have been as the progesterone part of HRT. I think there's been a bit of confusion with how long you can use Mirena for contraception and how long you can use Mirena for HRT. 5 years for HRT, after which it does need to be changed. Women with subtotal hysterectomies, I think, are quite difficult because they still have a cervix, even though they don't have a uterus. Now, women without a uterus don't need progesterone, but women who've had a subtotal hysterectomy may still have some endometrial tissue inside their cervix. So should we start them on estrogen only, which is a lower risk of breast cancer, or should we start them on combined HRT, which will protect their endometrium? And what I tend to do with these, I've got a clinical case in the discussion coming up, is I tend to give them 3 months of sequential HRT. And if they don't bleed with their sequential HRT, we can assume that there's not any endometrial tissue left in their cervix and change to estrogen only. And this is something that, as menopause specialists, the menopause specialist group in Scotland, we all tend to do, and we think it's a relatively safe way of approaching quite a difficult problem. Women with previous endometriosis, if they've had hysterectomies, then they may still require progesterone if their endometriosis was severe, because there may be deposits of endometrial tissue elsewhere in their pelvis. And HRT can cause a reoccurrence of the symptoms that they had from their previous endometriosis if they take it after menopause. It's really just to be aware of that. And women with fibroids. So fibroids shouldn't grow with HRT because the levels of hormones are much lower than they are in premenopausal women. But fibroids might shrink more slowly when women are using HRT. Women with fibroids can use Mirena or Levocert as a progesterone part of their HRT as long as they have a uterus that sounds to less than 10 centimeters. If their uterus is bigger than that, then the Mirena might be sort of lost in the cavity and not able to actually deliver progesterone to the whole cavity. And if they have fibroids, they shouldn't have a submucous fibre that's more than 3 centimeters, because again, that might impair the ability of the Mirena to deliver progesterone to the whole cavity. So just to be aware of that if they're thinking about using Mirena, which is sometimes a good choice because they tend to have heavy bleeding on HRT if they're using sequential. Okay, so moving on, I've got a myth-busting page. I was on holiday a couple of years ago and I read Davina's book, Menopausing, and I came out of it with my head a little bit mixed up because she makes a very convincing argument for a lot of the myths that I'm about to bust. And I get women who come to me who are convinced of this stuff. So the first myth I want to bust is that everybody needs testosterone. So it's been described as the missing piece of the jigsaw, and I don't actually think this is true. So testosterone levels decrease very gradually throughout one's reproductive life, whereas estrogen levels decrease quite steeply at menopause. We all make testosterone, but we don't just stop making it at menopause time. And we don't think that there is a role for giving it unless women have distressing libido symptoms. Sometimes women have problems with joint aches or pains or mood and want to try testosterone, but we don't have a lot of evidence that it actually makes a difference. So not everyone needs testosterone. HRT in women with no symptoms is something else I get asked about a lot. Should women who have no menopause symptoms whatsoever, those lucky people, should they start HRT? And that's really because women are wondering about the health benefits in terms of osteoporosis or cardiac disease prevention. And overall, if you look at women who are on HRT and women who are not on HRT, the overall mortality is very slightly less than women who take HRT. We are not yet at a place where we would recommend it for everyone if you have no symptoms. For most women in their 50s who have symptoms, the balanced risk of the HRT is probably a good thing for them to be on, but we would recommend it for no symptoms. I have a few women who've come to see me recently who've said, my mum had dementia, I want to go on HRT so I don't get dementia. There is absolutely no evidence for this whatsoever. There's some evidence for short-term cognitive improvement with HRT, but it's quite sketchy. And what the data about HRT and dementia actually says is for older women who take HRT between 65 and 79, the data is quite conflicting, but the studies are actually either neutral or they show a slight increase in the risk of dementia with HRT. So I think that that's worth bearing in mind, particularly thinking about prescribing it for somebody who is older. And there certainly does not seem to be a protective effect against dementia with either estrogen only or combined HRT. There's been quite a lot of things that I've seen on social media saying that Utrogestan carries no breast cancer risk. We've got one retrospective study that suggests 5 years use is safe, but it's only one study. And beyond 5 years, Utrogestan does seem to carry a slight increase in the risk of breast cancer. And Mirena certainly does seem, we think, to carry a small breast cancer risk as well. I've seen social media recommending Utrogestan and HRT as being no risk for women who have had previous breast cancer, and we just don't think that's the case. So I think you need to be quite careful with that. And then the next thing is estrogen levels guiding treatment. So should we check estrogen levels? And then if estrogen level is low, we give you more. If it's very high, we bring it down. We think particularly in perimenopause, estrogen levels naturally can be so up and down that they really aren't helpful in deciding what we should do with somebody's HRT, and we should titrate to symptoms rather than estrogen levels. Okay. There are a couple of exceptions to that we'll come to later in this talk. So a little bit about testosterone, because I got asked about this a lot. There's not a licensed form that we can use in the UK. Androfem is licensed in Australia, and some you can import it, but it's not prescribable on the NHS. So for most women, we use male testosterone, either Testogel or Tostran, that we use in a much lower dose. The main indication is libido problems, and as I've said, there's no evidence for joint pain, energy, or cognitive function, although anecdotally, some women do report these improve, but it's difficult to know if that's actually a thing or a placebo effect. We recommend checking testosterone levels before we start, not to guide whether they need treatment before, that should be based on symptoms, but to make sure that their levels aren't too high before they start. In all the years I've been prescribing testosterone, I've never met anybody whose levels have been too high before we started, but the recommendation is that we should do it anyway. And then we check again at 3 months. It's probably best to check levels, not when somebody on a day when they've just used the testosterone. We tend to use it 2 times a week to start with and then increase to 3 if we need to. But checking it the day that they take it can sometimes give a falsely high level. So usually the day after they've taken it, if they're taking it 2 or 3 times a week. And if it's too high, then you need to reduce the dose. And that's because if they go along for many months or years with a high dose, they are very at risk of getting frontal partum balding, voice deepening, and clitoral enlargement. And these things don't go away if you stop the testosterone. So they need to know about that. And if it's not helping, stop it. So if they've got libido problems, it's not going to fix the libido problem that's caused by job stress or money stress. It's not going to fix a relationship problem. It's only going to help a hormone problem. And quite often it's difficult to know if it's a hormone problem until you trial it, but if it's not helping, stop it. And if it is helping, then yearly review. We would normally always use it with HRT because it's more physiological, and we would check testosterone levels yearly to make sure they hadn't drifted upwards. Okay. Women who have contraindications to HRT, so you might have somebody who said previous breast cancer, or another reason we'll come on to contraindications in a little while. What else could we do for them? Well, I think for every woman who's got menopause symptoms, we should actually be having the chat about lifestyle. Sometimes you see somebody drinking caffeine to excess. We know that exercise is particularly good for both mood and vasomotor symptoms. Alcohol can cause anxiety and increases your breast cancer risk. Not everybody might want to stop alcohol, but I think it's about being mindful of how much you're drinking. And weight loss if they're overweight. And all these things are actually quite difficult to motivate people to do. There is good evidence that CBT helps both psychological symptoms of menopause, but also physical and vasomotor symptoms, which always surprises me. But provision where you live might be patchy. SSRIs and SNRIs can be effective at reducing vasomotor symptoms and also helping mood symptoms. And gabapentin can be good for women who have joint pain and have vasomotor symptoms. And whether I recommend one of these or the other will depend on the constellation of symptoms that woman has. Both of these medications can have side effects and they can cause weight gain, and not everybody likes being on them, but they're a good thing to be able to offer people if there is a contraindication to HRT. For the antidepressant side of things, paroxetine is the most effective, but can't be used by women who are on tamoxifen because it makes tamoxifen not work as well. And for gabapentin, we would normally start at a dose of 300 milligrams a day and gradually increase to a maximum of 1.2 milligrams, 1.2 grams a day. Okay. I'm going to say a little bit about fezolinetant. I don't know if any of you have come across this. So it's a new medication that's only been licensed for maybe about the past 6 months. So it's basically a neurokinin-3 receptor antagonist. You don't need to remember that, but it basically affects the thermostat in the brain. So in menopause, women become more sensitive to both heat and cold. And the window of temperature at which they're more comfortable reduces to be a lot narrower. And it kind of widens that window. It makes them more tolerant to heat. So it's very good for vasomotor symptoms. It's not yet Scottish Medicines Consortium approved. I can prescribe it, and I think that everybody in my region who's having it is going to have to come through me just now. Slightly frustratingly, the license doesn't cover women who are over 65, and it doesn't cover women with breast cancer. Now, it's non-hormonal, and I do have 2 patients with breast cancer that I've started on it, and I think the manufacturers are being quite cautious about this, but the license does not extend to women who've got breast cancer. It can have side effects, insomnia, abdominal pain, and diarrhea. But the main concern about it is liver dysfunction. So when I started prescribing it as per BNF, which suggested withholding it if there's moderate or severe impairment of LFTs or in women who had liver problems. But I don't know if everybody else got this, but this week I got this through my my mailbox. And I'm sorry, this is so slow. This is so little small writing. But it's a risk of hepatotoxicity. And now they're recommending that you check LFTs before you start, and then laboratory testing of LFTs at 3 months, every month for the first 3 months, then it's 6 months, and then at 9 months. So there obviously have been women who have had adverse effects on their liver from this, and I think that we just need to be cautious with it. But I think it's actually quite promising for women who can't take conventional HRT and who have vasomotor symptoms. Abnormal bleeding on HRT. So this is the other thing that's changed this year. We've had new guidance out from the British Menopause Society about what we should do for women who have abnormal bleeding on HRT. And it's actually really useful, but the guideline is really long. It's about 90 pages long. There's a really useful flowchart about 5 pages in, and that's what I would go with. So it says that women should be referred if they're bleeding 6 months after starting their HRT. But the bit I think that we're not very good at where I work is they should be referred sooner for scanning if they have risk factors. And if they have one major risk factor, so that's BMI over 40 or a genetic condition which increases their risk of endometrial cancer, such as Lynch syndrome, or if they have 3 moderate factors, and a BMI between 30 and 39 is a moderate factor, diabetes, PCOS, and there are other moderate risk factors, and they all pertain to women who've not had quite enough progesterone to cope with the estrogen that they're on. So I think a low threshold for referral if somebody has risk factors, and check the compliance. I had somebody the other day who was taking 1 HRT tablet every 3 days and having irregular bleeding. Vaginal examination to make sure there's not cervical or vaginal cancer there, and a transvaginal ultrasound scan. If the endometrial thickness is normal on scan, adjust their HRT. I'll come to how we do that in a second. And again, I think that's the thing that is often quite tricky. And refer if the bleeding hasn't settled after further 6 months, and refer sooner if the bleeding is heavier or more persistent. In clinic, when we see them, where I work, we tend to do a papel and we hysteroscope them if their endometrium is more than 11 millimeters, but different health boards have different rules. If we get a normal papel and they're still bleeding after 3 months after adjustments to the HRT, then we'll hysteroscope them. A papel only gives you 3 months of reassurance. A normal hysteroscopy gives you 6 months of reassurance if the bleeding hasn't settled, and I would want them re-referred after that time period. And again, checking their compliance and adjusting their HRT to try and settle that bleeding down. So what can we do to settle bleeding? So I think that's often the bit that in clinic as gynecologists we're not particularly good at. And I think I spend quite a lot of time in clinic having discussions with people about what we can do that might be helpful in stopping it. So we mentioned earlier in the talk that oral HRT tends to have a better bleed profile than transdermal HRT. So if they have no risk factors for clot, you could change them to an oral preparation. You could put Mirena in, and I think Mirena is a great solution for women who are on sequential HRT, particularly if bleeding's heavy. Quite often they are just done with periods, and putting a Mirena in may well fix that for them. It does take a bit of explanation, and again, they're often worried that they'll get side effects with it. So I think that's reassurance that they can have something else if it doesn't suit them. You can add in desogestrel pill, 75 milligrams. Someone will get a no bleed profile with that, or it will regulate things. Or you can add an additional progestogen or progesterone to the days when they have progesterone in their cycle for non-sequential HRT. The current guidance is to review after 3 months, because if you remember back to the breast cancer data, there's something about the combination of estrogen and progesterone that seems to go with a higher risk of breast cancer. And if you need to carry on for more than 3 months, you probably need to have a discussion that we don't know if it impacts breast cancer risk or not. If they're on Utrogestan, you may change them to a synthetic progesterone, which tends to have a better bleed profile. Often women are quite reluctant to do that because it can be a little bit more side effecty. And they also tend to worry about the breast cancer risk. And if they're young, if they're under 50 and they don't have risk factors, you could put them onto the pill. And some women actually get good symptom relief with the pill. The dose of estrogen is higher than it is in HRT. And again, it's quite idiosyncratic. Some women will have menopause symptoms on the pill and only HRT will work for them, but some women do get good relief on the combined pill. And then the other thing you could do is you could reduce their estrogen dose. So sometimes the endometrium is a bit unstable if the estrogen dose is a bit too high for the progesterone dose. So rather than increasing the estrogen, you could drop the estrogen dose a little bit and see if that helps, as long as their symptoms stay away. So lots of options there that could be discussed with the woman about what she wants to do. If they're on continuous combined, the options are very similar, and again include Mirena, changing to oral HRT, changing to a synthetic progesterone like norethistron, medroxyprogesterone acetate, or dydrogesterone. Increasing the dose of medroxyprogesterone acetate, if that's what they're on. If they're recently postmenopausal, and I sometimes think that women, are period free for nearly a year, they go into continuous combined or maybe just a year, and then they start having periods again, it might be sensible to consider giving them a year to sequential HRT because they may just have resumed some ovarian cycles. Again, adding additional progesterone, progestogen, or reducing their estrogen dose can also be effective, just as it is for women who are in sequential treatment. So I'm going to spend a few minutes talking about women who've got other health problems, which is what I spend quite a lot of my time in my menopause clinic doing. I'm going to talk a bit about gynae cancers. I'm going to talk a little bit about, there's some new guidance come up on the British Menopause Society and the British Gynae Cancer Society website that I think is really, really useful. So for women who have had cervical cancer, vaginal cancer, and vulval cancer, using HRT is generally really very safe. Endometrial cancer depends on what type of endometrial cancer they have. So there's low risk endometrial cancer, which is the normal endometrioid, or there's higher risk, which is papillary or serous, and what stage they are. I'm going to show you a table in a minute that tells you what to do. Ovarian cancer depends on the type. Serous or granulosa cell tumor, you might want to be a bit more careful of. And for all sarcomas, they're really estrogen sensitive. You should avoid systemic and vaginal estrogen as well. So the guidance in the gynae cancer guideline is actually really comprehensive. I'm going to show you the table from it. It didn't all come out particularly well. So this is the table. So it's got the type of the primary cancer down the side: ovarian, fallopian tube, primary peritoneal, endometrial, cervical, vulval, and vaginal. And then the subtype or stage in the middle column. And it's got a column for whether you can use systemic HRT or vaginal estrogen. Green is, yeah, absolutely fine. Feel free to prescribe in primary care. And the key to this is actually in the document on the British Gynae Cancer Society website. Yellow is, yeah, we think this is okay, but you might want to get specialist input just to check, because there might be some nuance about that. And red is, you probably shouldn't prescribe this. So I think it's a really, really useful document for us. Other non-gynae cancers, I think, are important to mention, and there was a good review article in this month's Post-Reproductive Health, which is the British Menopause Society's journal. And I think that sometimes these are quite counterintuitive and it's difficult to guess them. So esophageal and gastric cancer, we think HRT is fine, doesn't increase the risk. And interestingly, I saw a woman a few weeks ago who was referred to me who had previous colon cancer, and the surgeons are wondering if she could have HRT, and she should have HRT because for colon cancer, HRT reduces the risk of disease recurrence. Renal, thyroid, hepatic, leukemias, lymphomas, blood are all fine, but bladder cancer, CNS tumors, including meningiomas, and basal and squamous skin cancers, which is a surprise to me, have an increased risk. So I think that the bottom line from this is if you're not sure, then you can ask your local menopause specialist for advice about whether it's safe or not. And there's this very good review article in Post-Reproductive Health this month. Okay. So I was going to spend the last sort of 20 minutes of my talk going through some clinical cases. If we were a smaller group, we could have some discussion about this, but I think there's too many to make that a useful thing to do. So I'm going to approach this by going through the case and kind of letting you know what my rationale would be for treating this in clinic. And then if you've got questions at the end, I'm really happy to discuss it. And these are all cases that I've actually seen in my clinic, and maybe cases I've seen more than once in my clinic, but they are all made up. So Jenny is 70. She comes to see you because she's had vasomotor menopause symptoms for 20 years. She has been on Instagram, and with recent media attention, she's wondering whether she should start HRT to help with her symptoms. So this is quite a difficult one because we talked about risk benefit profile for women who come and are thinking about starting HRT. But it's a lot harder to discuss risk benefit profile for somebody who's 70 because we have less good data for them. What we do know is that they don't get that benefit in terms of cardiovascular risk. They may get some benefit in terms of osteoporosis risk, and we don't know if the reduction in bowel cancer applies to them. We do think that the risks of breast cancer and HRT are higher for over 60, so you would need to counsel her about that. And for women who are over 60, they're probably double the risks I quoted, and we don't have any figures really for women who are over 70. And there's also that controversial data about dementia and possible increased dementia risk for women who are 65 plus. We think for women who are over 65 that probably from a vascular point of view, getting transdermal HRT is better. And certainly it doesn't seem to increase stroke risk if we use transdermal HRT. So I would have a really good chat with Jenny about the pros and cons and see if she really wants to start HRT. And if she did want to start HRT, I would start her on a really low dose patch. She's been estrogen naive for best part of 2 decades. And if you start her on medium dose, she's going to get really sore breasts and maybe feel a bit sick. So I would probably start her another 25 or half a 25 microgram matrix patch. And I would probably progestin as her progesterone in a continuous combined regime, because we think it's more blood vessel friendly and it may have a lower risk of breast cancer. Okay, and I'd review her after 3 months, probably in my menopause clinic, and see if she feels better on it. And if she didn't feel better, I think I'd be inclined to stop. Okay, we'll do another one. So next one is Susan, who is 55, and she's been on transdermal, continuous combined HRT. It's a 50 microgram patch, and she's been on this for 5 years. She is aware of increasing joint pain and lethargy, and she is again interested in starting testosterone because she's seen lots of stuff on social media suggesting this is going to solve the problem. And I think this can be quite a difficult consultation because often women come into it with quite a clear agenda, knowing what they would like to start, but it may not always be what we would choose for them. So as we've already mentioned, we don't have good safety data on testosterone. We don't have a licensed form that we can prescribe in the UK. We can't say whether it's good, bad, or neutral in terms of breast or blood vessels because we just haven't done the studies in women. And I would ask her to have a think about that, but also we don't have any really good data suggesting that it helps joint pain or that feeling of lethargy or exhaustion. And what I might suggest, first of all, and it's in line with British Menopause Society guidance, is to increase her estrogen dose, first of all, and to optimize that. She's still quite young, and we think that's a very safe thing to do. And perhaps optimize her estrogen dose, get up to 75 or even 100, and see if she felt better on that, rather than going to something that we don't necessarily think is going to help and has an unknown risk quality. Okay. Next one is Emma's 51. She has low mood, anxiety, and is not sleeping due to night sweats. So she's got a full house of menopause symptoms, really. She had a DVT in pregnancy 25 years ago. She's on no other medication. She doesn't have any other past medical history. Is it safe for her to start HRT? And again, it's really difficult to advise this woman because we know that for women who've never had an episode of venous thromboembolism, transdermal HRT doesn't seem to carry an increased risk. But we don't have any data for women who had previous venous thromboembolism. Her DVT was a long time ago and it was provoked by pregnancy. So we've got a reason why it happened and she's not another one since. So I'm relatively reassured by that. So I think what I would do with Emma is explain to her that she could start a low dose of transdermal HRT. And again, I would probably start if she wants a 25 microgram patch. And I would probably again use progestin as my progesterone because we think it has less effects on blood vessels. But she would need to know that we wouldn't be able to promise her that there wouldn't be a risk of recurrence. And if she was concerned about that, she may want to start something else. She may wish to start an SSRI. She may wish to start gabapentin, see how they go. And I would offer her these things. And I would probably have a discussion with her about fezolinetant as well, particularly because her not sleeping is due to night sweats with appropriate liver monitoring. And I would see what she wanted to do and then review her again 3 months in. We've kind of answered this earlier on. So Sally had a subtotal hysterectomy with both the tubes and ovaries removed when she was 47 for a benign ovarian cyst. Wasn't starting any HRT at the time while we were waiting for the pathology to come back, but it was a benign cyst. She's now 3 months surgery and has menopause symptoms that are just destroying her life. She has no other medical history and a BMI of 33. So what HRT would you prescribe for her? Well, we did kind of answer the question because we said that we would normally start a sequential preparation. And if she had no bleeding, then I would be quite happy with her going on to estrogen-only HRT. And because her BMI is 33, that counts as a risk factor for venous thromboembolism. And I would start her on a transdermal sequential HRT for 3 months, something like Everel Sequi, and then I would change her onto estrogen only if she didn't have a bleed. If she did bleed, I would keep her on sequential until the age of 50, 51, and then change her over and see what happened. Okay. Lorna is 47 years old and is perimenopausal. She is on 4 pumps of estrogel with 300 milligrams of buprogestan 14 days per month, which is the recommended dose for somebody who is on a high dose of estrogen. She has symptoms of tiredness, irritability, and reduced cognitive function, and they were helped when she started HRT and after previous dose increases. Every time she's increased her dose, she feels better, and then it kind of wears off. And her symptoms are now a problem again. And she would like to increase her HRT further. And I actually find these really difficult. What I tend to do with them is discuss whether they would like to go on to an oral HRT. Sometimes that has better efficacy. The other thing that I sometimes do with them is this is the time when I might check estrogen levels to make sure that she's actually absorbing it. And if she's not absorbing it, think about another way of giving it either orally or via a patch. And if she's not absorbing it, then the options are to try and increase her dose or even to think about estrogen implants. But I think that these ones are very difficult. So if you increase the dose, again, you can get a little bit of tachyphylaxis and their symptoms can come back. And I think sometimes you need to have a very honest discussion with them about maybe the HRT isn't necessarily going to fix absolutely everything. My 6th case is Gillian, who's 42, and she's BRCA1 positive, and her mum and grandma have both had breast cancer. And because of this, she's seen genetics. They sent her to gynae, and she had a prophylactic bilateral mastectomy and oophorectomy last year. Since she's had her ovaries removed, she's struggling with really debilitating vasomotor symptoms. And she wants to know what her options are for treatment. And there's actually quite good guidance for this, again, on the British Menopause Society website. And the feeling is if you've had risk-reducing surgery, even though you're BRCA1 positive, it's absolutely fine to start HRT until the time of the normal menopause. And putting back a lower dose of the hormones that would be in there naturally doesn't seem to increase breast cancer risk. They should, however, stop it round about the age of 50 or 51, because continuing beyond then may increase their breast cancer risk, but she could certainly have HRT until then. 2 more to go. Julie is 47. She's got fibroids. Her fibroids measure 4 centimeters and 3 centimeters, and they're intramural, so within the wall of the uterus, not in the cavity. She's perimenopausal, and she has heavy but regular menstrual bleeding. She wants to start HRT, but she'd also like her heavy menstrual bleeding managed. So what factors would decide if she's suitable for a levonorgestrel IUD? So again, we've kind of answered this earlier on. So she could have a Mirena, provided her uterus extends to less than 10 centimeters. And that would maybe be an effective way of managing her symptoms, and she could use that with an estrogen patch. The other thing we could think about for her is a medication called Ripol, which is an oral GnRH agonist that switches off the FSH and LH, so acts a bit like Decapeptyl and switches off menstrual cycles, and it's got a little bit of HRT in it. So that's once a day tablet, and it's licensed for heavy menstrual bleeding with fibroids, but it has got some HRT in it, so that might be a useful thing for Julie as well to discuss as an alternative option. And my last clinical case is Mary, who's 55, and she started oral HRT a year ago. It made a huge difference to her quality of life. She loved being on her HRT. She had a STEMI 3 months ago, and the cardiology team stopped her HRT, and she feels dreadful. She'd like to restart it. And the question is, can she restart it? So there is some quite scanty data about this, and it's examined women who did and did not start HRT after they had cardiovascular events and after they had MIs. And a group starting transdermal HRT had a lower risk of a repeat cardiac event. So the answer is yes, she can restart her HRT, but she should have a transdermal low dose preparation. Okay. So I've just thought some resources would be really useful. So the British Menopause Society has got so much good stuff on their website. They have got consensus statements, they've got practical prescribing guides. Women's Health Concern is the patient-facing arm of the British Menopause Society, and they're fabulous for fact sheets. They've got a fact sheet on testosterone, menopausal hair loss. It's just a really good gynae website, and they've got good infographics that give kind of a realistic view of risk. British Gynaecological Cancer Society is actually a really good website that has that table that I showed with the can you or can't you prescribe HRT for when you've had previous gynae cancers. The NICE guideline, I think, is a bit out of date, maybe a bit simplistic now, but it's a useful reference point and shouldn't be forgotten about. And my last slide is a lovely Beryl Cook picture, just to remind you that not everybody has menopause, and some are actually quite glad to see the back of their periods and move on with the rest of their life. Okay, I'm going to stop screen sharing now and hand you back to Katie, who I think is going to field some questions.
Thank you, Faye. That was really, really interesting. And you'll maybe see in the chat function, there's loads of questions. So what we'll do is go through them. I think most of them have been covered already. So if you want to look back at the video of this later, you'll probably find a lot of the answers in there. But we'll go through them anyway. It's a good recap. So the first one comes from Sharon. Does continuous HRT increase risk of CVS and stroke if using more than 10 months, maybe, in a patient with age of more than 60?
So we think that it's very unlikely that getting transdermal HRT increases the risk of cardiac events. So if you use it into your 60s, we're going to use that protective effect that you get within 10 years of the menopause, but we don't think it increases the risk of cardiac events.
Okay. So Hamira says, hi, can you please talk about the use of HRT to help with perimenopausal symptoms when the patient is still having periods? I know you went into...
Yeah, absolutely. So it's a really good point. So perimenopause is a really horrible time. Often women get menopause symptoms, but they can also get exacerbation of PMS symptoms as the hormone levels start to go up and down more widely than they did in women's 30s. So it can sometimes be really difficult to tell what's PMS and what's menopause. So if they're really PMS predominant symptoms, I would tend to use quite a high dose of HRT. Women's own estrogen levels are going to be going up and down widely. So what the PMS guidance says is to start 100 micrograms of HRT if they have got really bad PMS symptoms. And the rationale behind that is that that's probably enough estrogen to switch off your own cycle. Or you can use the combined pill, again, to switch off the cycle and just give nice static hormone levels. If I'm using HRT, again, the guidance suggests using either Mirena or using Utrogestan because they're two less progesterone sensitive ones. And it's often really difficult to tell what is menopause and what's not. And often a 3-month trial to see if they feel better is what you need to do to kind of give you that, you know what the risks are, but the benefits kind of weigh up. So I think perimenopause is difficult. And if you're in doubt, a 3-month trial will let you know whether it's going to help or not.
Thank you. From Mayat, would you be starting HRT for 48-year-old woman with perimenopausal symptoms who has a family history of breast cancer in a first-degree relative? They've tried non-hormonal treatments which did not help.
Yeah, and again, I think a full discussion. So the first thing is, does she be referred to genetics? And I'm assuming that that's been done. If there's a strong family history, there's really good guidance on certainly Lothian's website about who requires referral and who does not require referral to genetics and who has an elevated risk and who doesn't. So it's good taking a proper family history and trying to figure out, is the risk actually elevated? Because sometimes when you dissect it all out, the relatives have been different sides of the family and you can be reassuring about it. We don't really understand how genetic risk and HRT risk interact with each other. and whether they are synergistic or whether the genetic risk is high and HRT is a bit of a drop in the ocean beside it. So we just don't really understand that. And I think that what you have to say to these women is that there might be a little bit of elevated risk, and probably their risk goes up in line with normal risk we'd expect with HRT. And are they prepared to take that on, bearing in mind they've got the background risk to think about as well? But it's a little bit of a, we don't really know. I would be quite laid back about them trying it as long as they accepted there's a bit of an unknown risk there. And again, I would use a low dose estrogen and utrogestan, because that big French study suggested no increased risk with that within 5 years.
Okay, so this will be another good recap. I know it makes me confused and probably lots of other people. Can you please repeat your practice with subtotal hysterectomy?
Yeah, absolutely. So subtotals are really difficult. So when I do a subtotal hysterectomy, it's often because things are so stuck I can't get the cervix out. I usually try and get the cervix out. There's a bit of a vogue, maybe 10 or 20 years ago, for leaving the cervix in, and we've got a little population of women who've got cervixes left there. And when I do a subtotal, I tend to core out, like taking an apple core, I tend to core the cervix out and get as much of the endometrium out as I possibly can. But it's always difficult to know if you've left a wee bit in there. And if you've left a bit in there, there's a chance that if you give estrogen only, that you can stimulate it and cause an endometrial cancer in the stump. Now, the rationale goes that if there's a bit of endometrium left in the stump, it will bleed with HRT. So if you give sequential and there's endometrium left in the stump, they'll probably have a bit of spotting as a withdrawal bleed. And if they have that, they should stay on sequential HRT as long as they're on HRT. If they don't have any bleeding, then it's probably safe to assume they don't have any endometrium left and it's all been cored out, and you can have them on estrogen only. Does that make sense?
Yeah, brilliant. Really good
Yep.
explanation. So from Philippa, those who don't have periods due to contraception use but present with other symptoms, would sequential or continuous be the option?
So I would probably start them on continuous, because nobody really likes having a period. So if they're on Sterel and they're bleed-free on Sterel, I would start them on continuous combined HRT. We can't use desogestrel as the progesterone bit of HRT because it's not licensed. So we would need to use continuous combined, but I would just start them on continuous combined. If they had any problematic bleeding, I'd probably change them to sequential.
Thank you. Betsy's got a good one. Once we start on HRT, is it okay to continue for a lifetime?
Oh, don't know. Nobody knows. I have a few quite recalcitrant old ladies, quite scary actually, who say, I'm going to be on this until the day I die, and it will come out of my cold dead fingers. I think every woman needs to have a chat with whoever's prescribing her HRT every year. And I think the reason for that is manifold, because her risk profile will change. So as she goes on, has she got any other health conditions that might make it better or worse for her to stay on her HRT? And also, what's our current understanding of HRT and risk and age? Because we don't have the data to tell us. The WHO study looked at up until the age of 79. So we've got a little bit of data about older women, but it's not really good data. And we just don't know. And we know that if you're on HRT for 10 years, your breast cancer risk is twice as high as if you're on it for 5 years using conventional HRT. If you use HRT into your 60s, your breast cancer risk goes up. So I think that that conversation needs to be had as women get older to make sure that they have the option to make an informed decision.
Thank you. And this is a similar vein for poor Omar, who says that he has this problem because he's a man, but he works in an affluent area, and lots of women want HRT without any really real symptoms, or they want to go on it for their joint pains or bone protection and then refuse to come off it. And he's got ladies in their 70s who are asking to carry on, and he wants to know how he speaks to them to ask them to stop. I guess it's all about the counselling that you're talking about.
Do you know, I think it's about risk and benefit as well. You know, I think that I would be reluctant to stop at anybody who feels they're getting benefit from it, but they may want to have a trial of it and see how they feel, because when you stop HRT, one of three things will happen. You'll either feel absolutely fine, and that's great. Your symptoms will come back a bit, but they won't be too bad, or it will be absolutely hellish. And you don't know which of these things are going to happen until you stop it. So I think as long as they've got the reassurance that you can go back on it, that makes try on stopping it a little bit easier. But there's not a finite length of time that I would say somebody must come off HRT, as long as they have that discussion every year. But I think working in an affluent area must be really difficult, because women come in and they're really informed, but they're not always well informed. So often the stuff that they have researched is maybe not the advice that we would give them as menopause specialists. And there's a lot of stuff on the internet that's just wrong. And often people clutch to that because it seems like a good solution for their problems.
Yeah, I completely see that. We have a lot of problems with this, particularly with everything that's been out in social media and in the media for the last 5 years or so. I think it all kicked off with Davina. So we're
Well,
still
I read the Davina book on holiday 2 years ago, 56, not on HRT, and I finished reading it thinking, oh my God, I just started as my menopause specialist. I just start, and it's a really convincing book. It's a really nicely written book, but the data in it is incorrect. And I think it makes things really difficult because people trust Davina.
Yeah, that is the problem. Then I have a question from Shadin saying, can we start HRT for women aged 40 to 45, or do we need to get bloods to confirm a diagnosis?
No bloods. If they've got symptoms, just start it. So what you tend to find is when women enter perimenopause, quite often they get disruptive symptoms just before their period starts, when their hormones are going to be lowest. And I think if somebody's in their 40s and they've got symptoms that they feel strongly are menopausal and they sound like they're menopausal, if it's stuff that you think this isn't menopausal, I probably wouldn't. But doing their LH and FSH will tell you no more than you can deduce by asking them how old they are. So if somebody's periods have stopped under 45 and I want to know why they've stopped, is this menopause, is it PCOS, I might do the bloods on them then. I wouldn't do them on anybody over 45. But if somebody has what sounds like a menopause symptom, and sometimes they have a family history of early menopause as well, I would just trial HRT and see how it goes. And if they feel better, great. If they don't feel better, then it's probably not menopause.
Thank you. How do we delay a withdrawal bleed on sequential combined?
Oh, you
HRT?
could just, yeah. So for like holidays and stuff, yeah, you could probably give them, so if they're on a patch, if they're on an Everell Sequy patch, just get them to continue if you open up a Everell Sequy box, there's Everell and there's Everell Conti, just get them to put another couple of Everell Contis on and then chuck away the Everells from the box and start a new box after that. If they are on oral HRT, then get them to, it means wasting half a packet, but just get them to take the second colour of tablets in the pack straight on from the last pack and to chuck the estrogen ones, and that will frame thing by a couple of weeks.
Perfect. How often can we titrate HRT? Is there a time frame?
I think it takes good. So some women, when you change dose or start HRT, will feel better from absolutely get-go from day 2 or 3. But for other people, it's a much slower burn. But by about 2-3 months, you'd see if there's been a change. So I would say at least 3 months before you start hiking it up.
Thank you. That's really good advice. Do you have to check annual FBC for testosterone as you do for men?
No, written guidance. Sorry, I don't know why you do it in men, but I've never done that.
Brilliant. May I know if this is from Maya? May I know if we can still use clonidine as non-hormonal HRT to control vasomotor symptoms?
You can, but I've never seen anybody's ever benefited from it. And I think the most recent NICE guidance suggests against using it. Just it doesn't work very well and it can be quite side effecty. So I don't prescribe it very often. I sometimes discuss prescribing it with my breast cancer ladies as one of the non-hormonal options. But I think now we've got much more effective stuff like fezolinetant, and I would normally have a discussion about SSRIs or SNRIs or gabapentin with these women. I think that they've got better evidence of efficacy and they're better tolerated, and I would probably then line up one of those instead. But if somebody came to me and said, I want to try clonidine, I would be, yeah, absolutely.
Okay, and following on from that, is it possible to repeat the choice of SSRIs that you'd advise?
Yeah, so there's a really good, again, British Menopause Society website. I'm not sponsored by them or anything, it's just great. They've got a really good fact sheet for clinicians on non-hormonal alternatives to HRT. So the most effective one is paroxetine. other ones with good efficacy are venlafaxine and fluoxetine. And I would normally start paroxetine at 20, and you just need a low dose, you don't need to have a really high dose. Venlafaxine start at 75 and fluoxetine start at 20 as well. And I would give it 3 months and see how they went. Fluoxetine and paroxetine interfere with tamoxifen, so you shouldn't use them when you're on tamoxifen, because often the discussion we're having is with women who are who have breast cancer. You just need to check that you've got a breast cancer patient.
But good to go with venlafaxine and tamoxifen.
Yeah.
Yeah, great. Okay, next question is from Kazim. Kazim, any guide on when to adjust HRT in abnormal bleeding? Is there a watch and wait period? You were talking about
Yeah, so I think that it depends on the risk factors. So if they've got one of these major risk factors, the BMI is over 40, they need to be referred for a scan basically straight away without waiting for 6 months. So the guidance is that for the first 6 months of HRT, then bleeding's so common that advice about adjusting the HRT can be given, but it should settle itself down within 6 months as long as they don't have these additional risk factors. After changing HRT, if you've adjusted it, I would give it 3 months and see if things settle after that.
Great. So Omar's written back again. What's the guidance of changing from sequential to continuous? Should we change after 1 year of sequential or everyone after age 50? And another question from them, is topical estrogen at low dose for vaginal atrophy safe, or does it carry the same risk?
Okay, so let's do the first one first, but you might have to remind me the second one because my brain's not as sharp as it used to be and it's evening. So the first one was, just remind me again, sorry.
It was changing from sequential to continuous. Should we?
That's right. So there is evidence that the more progesterone you have, the better protected your endometrium is. So if you're on sequential for more than 5 years, because there's less progesterone, your endometrial cancer risk starts to go up a little bit. So the guidance is if you've been on sequential for 5 years, you should change to continuous combined. I would change anyway at 54 or 55 because most women will have stopped their periods by then, and better endometrial protection, and you won't have a period.
Perfect.
But no need to change after just a year.
And the other part of the question was, is topical estrogen safe for vaginal atrophy?
Yeah. Yes, with one exception. Or maybe more than one exception. So you saw the chart that I did in the British Gynae Cancer Society that suggested we shouldn't use it for women who had previous uterine sarcomas or leiomyosarcomas. The other caveat is so vaginal estrogen is really safe, and the phrase I tend to use to patients is the amount of hormone that you absorb from using vaginal estrogen, whether it's an E-string or Vagifem or cream, will be equivalent to 1 HRT tablet a year. So very, very small amount to get into your system. And it doesn't increase risk of breast cancer. It's really safe. You can buy it over the counter now. The one exception to that is women with breast cancer who are on letrozole, because letrozole does really horrible things to your vagina. So it makes it really, really atrophic. And it's so atrophic, all the blood vessels are really near the surface. And if you put estrogen into that, you occasionally get a bit of a spike in the estrogen levels. So I would refer women who are on letrozole who have problems with vaginal atrophy and are interested in using vaginal estrogen. I'd use lubricants first of all, but I would liaise with their breast cancer team, because what we sometimes do with these women is we change them to tamoxifen. So tamoxifen will act at breast and will blind the breast to the effects of the estrogen, whereas with letrozole, you're dumping the estrogen levels down as far as you can, and the HRT may just bring up a tiny shade. So letrozole and uterine sarcomas are the two that I'd be really careful about. Apart from that, yeah, really safe.
Great, thank you. Is a sequential combined patch available at the 25 microgram dose, or do you have to split patches to get to this?
Split patches. Somebody will make one sooner or later, but yeah, it's not licensed. Just cut a matrix patch in half. Or use a 25 microgram patch and additional progesterone. Let's have a chat with her about what she wants to do.
So you've already kind of touched on this when we talked about stopping a withdrawal bleed, but practicalities for sequential, do all packs come with meds which are clear to say when to take them during the month? I think you've already said that.
So I think every else sequence is quite confusing.
Oh, is
so
it?
Yeah, it comes in a, because the in the pack there's Everel Conti, which is the estrogen, and then in the pack there's Everel Conti, and Everel's just the estrogen, Everel Conti is a combined bit, and they look the same. So there are a few women over the years who've just been putting a patch on without actually looking at it very closely, and then they come in with irregular bleeding because their patches are all mixed up. Because they, unless they've taken the leaflet out and read it, and I think sometimes people just don't do that very well. I've also had a gynae colleague who, when the patient said to them, well, Everel patches and Everel Conti patches in the box, went, well, that's not right. They've given you a box, you're on Everel Sequi. So I think this sometimes you don't actually see what it looks like when you prescribe it. So I think it is important to understand what the patient actually gets. But I think Everel Sequi is particularly confusing.
Okay. How do you choose which brand of transdermal patch to use?
That's a good question. So I usually ask women what they want. So I quite often prescribe Estradot, which is really tiny. And a lot of women quite like that because it doesn't show up as much. And you can pop it on your bottom and nobody will see it, where some of the matrix patches, particularly the higher dose ones, are a bit bigger. So I often prescribe that. I usually find out what women want. I quite often prescribe Everel, and I think it's just because I can spell it. It's just, I think we just all have ones that we go to. So for the estrogen onlys, Everel, Estroderm, and Estradot are kind of my go-tos. For oral HRT, I tend to prescribe quite a lot of Femiston because it's got dihydrogesterone and everything that's got a lower breast cancer risk.
Okay, thank you. Another question from Peggy. Is there a place for continuous combined HRT? Some patients may prefer to have just one tablet instead of two. So for patient choice, I guess.
Yeah.
If they just want, yeah.
Yeah, I think patient choice. Yeah, absolutely.
Can you explain the risk of testosterone again, please?
We don't know. So do you know when we have an HRT consultation, I'll sit down, I'll say to them, this is the risk of breast cancer, this is the risk of ovarian cancer, this is the reduction in bowel cancer, these are your background risks, what do you want to do? I can't give them numbers of testosterone. I don't know. I've done research in women to say whether it increases or decreases the risk of breast cancer. We don't know whether it increases or decreases the risk of stroke or blood clots. We just don't know. We don't have any of that. In terms of side effects, it's actually really well tolerated. You think people would come back complaining of hair growth and things, they tend not to. I had one patient with cystic acne when she was a teenager, and it came back with testosterone. And she liked the testosterone so much, she decided to keep the cystic acne, which must have been she really liked it. But I think that in terms of general health risks, we just don't know. The data will come eventually, but there's not any research into it just now, and there's no drive to research it because we're using it in an unlicensed way. So we just don't know.
Okay. Someone's asking if they can have access to the recording. Yes, you can. And you'll get an email after tonight to show you how to access that. Fatma says, what about women with hysterectomy but still has one ovary and debilitating symptoms?
I'll just start HRT. So hysterectomy on average, if you have a hysterectomy and you have ovarian constipation of either one side or both sides, on average, you'll have a menopause that's 6 months earlier. But for some women, the menopause won't be earlier. For other women, they'll have a menopause quite soon after it because their ovarian blood supply has been compromised during the surgery. And there's not really a way we can test that. So if they've got symptoms of menopause after hysterectomy, I would just start HRT.
Okay, brilliant. If a patient has a family history of breast cancer, her sister has had breast cancer at 49, not BRCA, and not personal history of breast cancer, could she benefit from HRT?
So if she's really symptomatic, she might want to start HRT. But again, similar to the question we asked before about family risk, we just don't have research to see how family risk interplays, particularly for these women where we don't have a genetic cause. It's not like I've had BRCA and we've done risk-reducing surgery, which takes the risk right down. So HRT is not going to increase them that much. We just don't know. And there'll be a population of women where we can't pin down a genetic reason, but they will still have an increased familial risk that maybe we just can't test for yet. And I think we just have to say to them that we don't know if that HRT is going to be a drop in the ocean compared to their familial risk, or whether it might compound their familial risk. So we're asking them to take a bit of a leap into the dark because we don't have the data. If they want to start it and the symptoms are distressing them, I'd be fine about starting it, but I'd also have the conversation about non-hormonal alternatives that might not carry breast cancer risk with them and see what they wanted to do.
I think it's a lot to do with collaboration, isn't it, with the patient? It's a lot
Yeah.
about and taking that shared decision making, which is really important in HRT.
Do you know, it's really, I had a patient who's a previous breast cancer who was referred to me, and I said, you know, so what menopause symptoms have you got that are distressing you that you want to start HRT for? And she said, well, my nails aren't very nice anymore. And what other symptoms? And she's like, no, that's it, just my nails. I'm like, well, then you should start. So I think it's about finding out what the patient's symptoms are and what's distressing them and what's important to them, but also putting that in the context of what risk there is as well.
The next one, I love this, from SS. What's the name of the oral GnRH agonist again that's useful in fibroids and has a bit of HRT, please?
Oh, Rycol, and it really upsets me the way you spell it. It's RYEQO with no U after the Q. So RYEQO, Rycol.
Okay,
It's just been licensed for endometriosis as well.
great. So hopefully we'll
And it's
get
like an
that
oral
to
equivalent of
the name.
decapeptyl and back HRT.
Okay. If switching from high dose transdermal to oral, would you up titrate again or start high dose oral?
I'd start 2 milligrams, top of the licensed dosing range.
Okay. How do you normally advise patients to come off HRT? I think we've touched on that one already.
Yeah, slowly. So I would, if they're on a high dose, just gradually lower them, probably over about 6 months, just titrate them down, because that seems to reduce symptoms in the short term. And also, at a time of low stress, don't do it when your whole family's coming for Christmas or when you're about to go on a holiday somewhere hot. Just like common sense.
And how about cutting patches to?
Yeah.
Yeah.
So matrix patches can all be cut. And they don't have to be cut in half. You know, they can start with a Everell Conti patch and they can cut sequential bits off as the patch gets smaller and smaller over a while.
How are you doing, Faye? We've got 10 minutes left. You feel bombarded?
Yeah, I'm still up for it. Yeah. Yeah.
Okay, so patient with stroke or TIA having perimenopausal symptoms, which would be the best HRT?
Low dose transdermal utrogestan.
Okay, perfect.
We also discuss non-hormonal alternatives. So there's no increased evidence of stroke risk, even older women with transdermal HRT. But again, we don't have evidence for women who've had a stroke, what happens to them. So I've also had a conversation with women about low-dose transdermal utrogestan versus non-hormonal alternatives. And, you know, what are their symptoms? Is this something that we can fix with non-hormonal stuff that might be lower risk for them? So it's about, again, finding out what's important to them.
Okay, I started a patient on sequential for perimenopausal symptoms and followed her up in 4 weeks, and she said she didn't get a period since her last consultation, and so didn't start the HRT. Okay, as sequentialist started in first 5 days of the cycle, she was 52. Can I switch her to continuous? I think you said yes.
No.
No?
Well, no. So if it's not been a year, I'd start them on sequential, but I would if they're not having regular periods, I would just start them on it. They might have a bit of irregular bleeding to start if they have an ovulation, but it'll settle down.
Okay. If a perimenopausal patient has a Mirena in, shall we use combined or estrogen only? And if combined, shall we use sequential or continuous?
So Mirena in for less than 5 years, just use estrogen only. At 5 years, you have to change the Mirena or change to a different preparation. So if she was 54, I would give her continuous. If she was under 54, I would give her sequential. But the Mirena will still have a bit of oomph left in it. So what you might find is you give her sequential, she doesn't bleed. It's fine.
Okay. But I think I've asked you before about this, but so you can have a Mirena in, can't you, and take extra progesterone.
Progesterone, yeah. So you can be using the Mirena for contraception. If it's put in after you're 45, it will do you for contraception until you're in your 50s, you know, forever. But if it's been in for more than 5 years, you need to use additional progesterone or change the marina.
Okay, thank you. Is there guidance on patients who wish to stop HRT? Can this be stopped abruptly, or do they need to be weaned off gradually?
So it's nicer to wean them off gradually, but it's not dangerous to stop it abruptly. It's just nicer for them to come down gradually.
Okay. I wanted to clarify if I understood it right. If having irregular bleeding on HRT, we could do a trial of adding on a second progesterone to help the bleeding. Is this right?
Yes, absolutely. So you've got a choice. All the choices are in that big unscheduled bleed on HRT guidance that's on the BMS website. So you've got a number of choices, changing to oral. You could add in another 100 milligrams of utrogestan at night time, even on top of something like, Everol Conti. You could increase the dose of medroxyprogesterone acetate if they're on that type of HRT. You could put in a marina. So I think it's all about the balance between estrogen and progesterone. If you've got unscheduled bleeding, you can either drop your estrogen dose or you can increase your progesterone dose. But the most recent guidance is if you're going to increase the progesterone dose, do it for 3 months and then review it. If you stop it, it might stay settled, you might stabilize things, but if it comes back and you have to start it again, you probably need to have a discussion with them about we're not entirely sure what this does to your risk of breast cancer.
Okay. Simon is asking if there's a typical type of patient profile you tend to go for utrogestan.
No, just somebody who has side effects on conventional HRT, somebody who might have additional vascular breast cancer factors. I do tend to discuss it with people. It's on Lothian's formulary now, and we're only meant to prescribe for people who've got side effects on HRT. But if there is data that suggests it might be safer in terms of breast cancer risk and less side effecty, I think that probably it's reasonable to discuss it with women who are concerned about that.
Okay. This is a good one. Can you comment on safe contraception while on HRT?
Yes, so you do need to use contraception until you are 55. So marina is a good choice because it's a really good contraceptive and it's a really good endometrial protectant and it seems to be a very safe thing to use. Progesterone only pill. If somebody is young and fit and in their 40s, then the combined oral contraceptive pill may do the job of HRT and provide contraception as well. So that's a possibility. Implants, fine. Just don't presume that HRT is contraceptive and use something else, I think is the message.
You mentioned not checking estrogen levels as a default. What are the exceptions to this where it might be helpful? You've touched on that already.
So we really think it's not very helpful. I think the only time that I'm really doing it now is for women who feel that they are still having symptoms on the top dose of HRT and who would be wanting to go above that top dose. And it's really just to kind of prove to myself and them that they are actually absorbing it. And if they're not absorbing it, then to figure out how we're going to get them to absorb it. But it's now no longer recommended. If you're on 50, I think you should go up to 75. Just go up to 75 and see if you feel better.
Great, thank you. So is somebody who's a nullip more at risk for breast cancer with HRT?
It's not a big risk factor. I think nulliparous women are generally at more risk of breast cancer, but I don't have figures for whether that increases your breast cancer risk specific to HRT or not. But the background risk will sort of feed into your overall general risk. What's really interesting with HRT is you've got a population of women who are overweight and a skinny population of women, then HRT does this to the risk. So the absolute increase in risk is lower for the women who are overweight because their background risk of HRT is higher to start with. And what I don't know is if that applies to women who are nulliparous as well, because the obesity thing is about endogenous estrogen production, and we don't understand the mechanism whereby parity interacts with breast cancer. But it's really interesting. We just
Tricky. Can you please remind us of the name of the new drug for vasomotor symptoms?
Esolinetant.
Yeah, I couldn't say it. I had to use its brand name.
It's called Visoa, but Esolinetant.
Okay. Simon says, "Soz for being pedantic. Do you tend to change to continuous combined at age 54 or 55?"
Oh, I can never remember. 54 I think's fine. And if they have a regular bleeding on it, just put them back on sequential.
Okay.
And give them extra progesterone.
Antonia just saying, just to clarify, women who are on 100 micrograms patch or 4 pumps of gel, do they need 200 or 300 milligrams of butyrogestan?
So they need, if they're on continuous combined, 200 milligrams the whole time, rather than 100, which is what we'd use for lower doses. And if they're on sequential, they need 300 milligrams for at least 12 days every month.
Great.
So higher dose if you just an extra 100.
So I know you've already put these out, but I don't know if people may have missed this, but Sadia and Simon have asked for resources to signpost patients to.
So Women's Health Concern would be my absolute go-to, just for general gynae stuff. It's got really, really good information about HRT and risk. It's got a patient information leaflet on testosterone. It's just a really good website.
Okay, thank you. Really, this is a good one. Would postmenopausal bleeding be a contraindication to starting vaginal and systemic HRT until investigated?
So investigate first. But if you've on HRT and you have unscheduled bleeding, you don't need to stop it unless
Okay.
you want to.
I think you've already answered this. A lady on combined oral contraceptive wants HRT. Can she have it? If yes, what preparation can she have?
So this is a really good question, actually, because I've changed my mind about this over the years. So I used to think that if somebody's on the pill, they've got loads of estrogen. It's got a much higher dose of estrogen than HRT has. So if they're on the pill and still got symptoms, I used to think, well, it can't be menopause because we're putting buckets of estrogen in there. There is a population of women who have menopause symptoms that get better on HRT that don't respond to the pill. So the pill's hormone is ethinyl estradiol, and it's just estradiol that's in HRT. And there's a population of women who have a different response to that. So if somebody was on the pill and they wanted to start on HRT, I would probably start them on a relatively high dose, a 75 or 100, because they've been used to quite a lot of estrogen. But I'd have to think about contraception with them, what we're going to do about contraception. I would have them on the pill and HRT. I think that's really overkill. So I'd stop the pill, start HRT, maybe with a Mirena if they need contraception, so that might be quite a good way of giving it.
Okay. And I think we're right at the very end now, so I'm going to ask this one last question.
Okay.
Coming from Diana. Could the implant cover contraception up until 55 and HRT on top?
Yes, but you need to change your implant regularly in line with recommendations.
Okay,
I can't remember if it's
perfect.
3 years or 4 years. So you give the HRT as well. You couldn't use the implant as a progestin bit of HRT. You would need to use continuous combined if they have no bleed profile or sequential.
Okay, thank you, Faye. We have been asking you so many questions. That was really impressive.
My brain has melted now.
Time for the wine.
Yes.
But thank you so much. I think on behalf of everyone who's been on the call tonight, thank you
Pleasure.
so much. It's been really informative.
Thank you all for being so interested and asking so many good questions.
Yeah, I think there's a big gap, and we need this kind of education. It's really important, and things change all the time, so it's really useful to have this. So on behalf of the RCGP Southeast faculty, I'd like to say thank you to Dr. Faye Rodger, but also to everybody else who's been here tonight. Thank you so much, and I hope you can come and join us again for our next webinar.
Okay, thanks very much, Katie.
Bye-bye.
Bye.